A nombre del señor embajador de la UNESCO, Jorge Herrera Ramos, y Chairman del World Congress of Neurosurgery, UNESCO ASPNet, Walter Dandy, in honor of Professor Yaşargil, a quien agradecemos por la organización de este magno evento, así como a la doctora Deyanira Capi Casillas, Chairman del capítulo ANS IPN, al doctor Salim Abdul Rauf, Chairman de la Walter Dandy Neurosurgical Society, al Dr. Babak Kateb, Chairman de la Society for Brain Mapping and Therapeutics y de Brain Mapping Foundation, todos ellos vice-chairmans del comité organizador, y al Dr. Méndez Guadarrama Ortiz, Chairman del Centro Especializado de Neurocirugía y Neurociencias, México. Es para mí un honor presentar la siguiente ponencia a cargo de la doctora María Magdalena Méndez, quien es director del Departamento de Cirugía Neurovascular Pediátrica del Hospital General de Massachusetts, Boston, Massachusetts, profesor de neurociencias en Harvard y de ciencias de la salud y tecnología, Boston, Massachusetts, presidente y director general de Weblix May, neurocirujano jefe del Hospital General de Massachusetts. Hoy nos deleitará con la ponencia Desafíos en neurocirugía por COVID-19. Thank you. Dr. Natalia, can you introduce?
Thank you, Dr. Francisco. Hello, everyone. Thank you for joining us for the second week of the World Congress of Neuroscience in honor of Professor Gazi Yaşargil. I'm talking on behalf of the chairman of the Congress, Dr. Jorge Ramos, ambassador of UNESCO and president of the World Congress. We have our vice president of the World Congress, Dr. Deyanira Capi Casillas, president of the WNS IPN chapter, and Dr. Salim Abdul Rauf, global president of Walter Dandy Neurosurgical Society, and Dr. Babak Kateb, president of the Society for Brain Mapping and Therapeutics and Brain Mapping Foundation. Honor chairman of the committee, Professor Nasser El Gandour and Professor Marcus Rota. And thank you to Dr. Méndez Guadarrama Ortiz, director of the Specialized Center for Neurosurgery and Neuroscience. So it is the Congress of World Congress of Neuroscience, the World of Neurosurgery at your fingertips. And we had many male speakers last week, and only few of them were female. So we're really happy to have today our Dr. Maria Magdalena Méndez, like one of the female speakers. So it's really a pleasure to have like women in such difficult specialty, and especially the doctor like you, director of pediatric neurovascular surgery department at Massachusetts General Hospital in Boston, professor of neuroscience at Harvard MIT Health Sciences and Technology, and chairman and CEO at Weblix May, chief neurosurgeon at Massachusetts General Hospital. So it's really interesting and challenging topic today the doctor would like to discuss for us. So I think everyone will enjoy to listen to this. So Dr. Maria, you can start. We are happy to hear you and to listen.
Okay. Well, hello everyone. And well, first of all, the ones who knows me knows in normally times conferences, presential conferences, I'm always surrounded by residents or colleagues because I have autism, and speaking in public is something that makes me a bit anxious. So this time when Jorge Herrera asked me for doing that was a challenge, like doing this.
Dr. Maria, we're really happy to have you, and we hope that you will enjoy to give their talk, and like it's really interesting for us to listen to you. So you don't have to worry, you can feel like in family atmosphere, you know, there is only few of us, so you are alive and that's fine.
Yes. I want to thank you, Fernando Rodriguez, a resident from my original country, Uruguay, to be here with me today. She does an amazing scientific researching all the papers and articles published about the topic for today. So when I finish, I'm sure that you will enjoy a lot her presentation. So I will start it. Okay. So last December 2019, the novel severe acute respiratory syndrome coronavirus 2 emerged and resulted in a formidable outbreak that constitutes a global public health emergency. The pandemic has had drastic effects on healthcare. The demand for intensive care units capacity has increased significantly. The focus of healthcare activities shifted to the pandemic, having a negative impact in management of other conditions, and presents a challenge for the neurosurgical, like most specialties, delivery of care. Neurosurgery warrants special considerations because many of the treatments required are time critical. Lack or delay on diagnosis or intervention may lead our patients to permanent neurological injuries, deterioration of functions, declining quality of life, and even death. So we face a wide array of challenges with multifaceted implications like ethics, legals, and practicals. These include from staff being assigned to other services outside neurosurgery, treatment priorities, ethical decision-making, medical legal risk, till uncertainties for teaching and researching. These challenges affect us not only as doctors, but as humans. We have a moral duty to contribute to this crisis, but we also retain the duty to take care of our individual patients. So the pragmatic approach leads us to redeploy existing bed capacity and reconfigure our workforces. Outpatients activities has been reduced. We have more telemedicine than presential consults, and elective surgical procedures have been considered, both to redirect resources and to lower risk of transmission of the disease. That takes us to the challenge of prioritization of neurosurgical cases with our limited resources, which make us face new ethical dilemmas and being exposed to moral injuries and medical legal risks. Within a short period of time, we developed new working, teaching, and researching models to ensure safe in practices as far as possible and mitigate the negative consequences of this pandemic. With redeployment, we have two important considerations. First, we need to maintain a minimum staff for safe neurosurgical practices. So firstly, we try to redeploy trainees and leave senior staff to provide care for neurosurgical patients. Second, there is the risk of skilling if the redeployment lasts for too long. Neurosurgery is a craft discipline, and we need regular exposure to operative practices to maintain highly specialized skills. When we face the priority settings challenge, we have the first priority clear. We need to maintain the system fairly and protect patient safety. Our leader here is the ethical principle of justice. We aim mainly for time-critical conditions. We probably need to adapt substandard treatments to cope with demand and deal with the fact that the prognosis for many neurosurgical conditions is better than severe COVID-19 and the risk of transmission to staff and their patients. The present crisis is likely to put us, neurosurgeons, under pressures not previously encountered in normal times. Parameters that were irrelevant or inappropriate previously may now direct our decisions to treat. Factors may include availability of drugs, equipment, operation room time, and the intensive care unit capacity, but also life expectancy after surgery and the age of the patient. Withholding or delaying neurosurgical procedures may result in significant neurologic impairment or even death in patients who would otherwise likely have faced a more favorable outcome. Such neurosurgical patients should not be unjustifiably disadvantaged. Neurosurgeons must continue to act as advocates for their patients' health needs during this pandemic, in particular their patients' rights to equitable access to healthcare. And from there, we are in front of the ethical challenges that like the risk of injustice against patients, the need to guarantee equitable access based on clinical needs, and the exposure to moral injuries, the psychological distress suffered by healthcare workers that results from action or inaction, and violations of the ethical code. Ethical medical practice is based on the premise that clinical decision-making is fair and it's morally justified. Prioritizing the management of COVID-19 is understandable, but this approach inevitably limits the access to healthcare by other patient groups, leading to collateral damage and potential inequalities in healthcare. We must therefore establish strategies that recognize and mitigate healthcare injustice against our patients by continuing action our own practices, participating in high-level decision-making, acting as advocates for our patients. We could also engage with patient peer support groups to enhance awareness of their particular needs. So we all know at least some patients are currently unable to obtain or are frightened of accessing healthcare because of the pandemic. Neurosurgical patients should not be left feeling neglected, but instead be assured that provisions are in place to address their needs. But from that point, we jump into the medical legal implications. There is a potential increase in clinical negligence, timely decision-making to mitigate dual risk, but they are still there. Later, we need to think in the future. In the teaching and researching problems, we are using distance learning tools that makes an impact in their pathways and create new opportunities, like this one, for example. But we have reduced or ceased some clinical and labs activities. So that's all. I want to thank you for the opportunity to be here. Like I say, this is an amazing opportunity. Things like this, I think, will be last after the pandemic, because it permits that people all around the globe know out things that otherwise we only hear in conferences, and we know most of students aspiring to be a neurosurgeon doesn't go to our conferences. So I hope this is a good thing that will last after the pandemic. Also, the thing that I will like to say is that we need to keep things good after pandemic like this, but we will have more challenges after we finish the pandemic. We will go back to hospital like a normal life, but we will encounter things that will be no normal, like all people that will not be there because we lost them on the pandemic. So I think keeping things good are a point, make us stronger if we pass this. That's it. Keep the good and remember the colleagues, patients, and other medical health staff that we lost in this war.
Yes, thank you, Dr. Maria Méndez. It is
Fernanda,
short, but it is very okay. But it is short, but it is very good presentation. So all great is short, as it was said. So it's really good. We really thank you for your time, for joining us, for sharing your experience. This topic is really controversial. We also have discussed it with all doctors who were participating in the first week of the Congress. And we really do agree that it has impacted the educational level, the more free access to different really conferences like lectures. Students, for example, I'm able to visit this, I'm able to see many doctors, and that's great. as well as we really have to learn a lot from this pandemic and do a lot of conclusions. And I'm sure you and your team as a doctor also did a great impact in treating patients, in dealing with these problems in your hospital, in your department. So, and please also be careful, take care, like we need you, we need all great neurosurgeons, great doctors to take care of our patients, especially the difficult ones. So it's like, yeah, we unfortunately we don't have any questions in our chat. I don't see it, but I think it is not a problem because like I guess you have explained your mind and we're really happy to have you with us. So, and thank you, Dr. Maria Fernanda, as well for joining us. It's a pleasure, really. Thank you for joining us, for sharing your knowledge and experience. It's really nice.
Okay. Hello, everyone. I am Dr. Fernando Rodriguez. Thank you very much for inviting me to this conference. I am actually doing my neurosurgery residency at Clinical Hospital in Uruguay. And today I'm going to talk about neurosurgery in times of pandemic. I'm going to share the screen. Just a minute.
Yeah, we can see that.
Okay. Okay. COVID-19 first reported in China in December of the last year is a global pandemic that potentially can cause severe infection, respiratory failure, and death. This virus, positive sense single-stranded RNA virus, is the seventh determined coronavirus that infects humans. The median incubation period is approximately 5 days, and practically all patients experience symptoms in 14 days after exposure to the virus. The World Health Organization reports has been responsible at the date for more than 90 million of confirmed cases, with more than 2 million deaths globally. As a novel virus, the death rate for COVID-19 is higher than typical influenza seasonal viral illness. And as influenza also do, disproportionately affects the elderly and patients with major comorbidities. But what makes this virus so dangerous, and why does it concern us so much? The answer lies in the high rate of transmission and virulence. What is not only associated with these mortality rates, but also risks putting such a strain on the healthcare system that other patients will not be able to receive urgent treatments. In particular, respiratory failure from COVID-19 leads a rate of intubation requiring ventilator beds, creating a shortage of intensive care units capacity, making the treatment of all critical diseases extremely difficult or even impossible. This is called by some authors as collateral casualties, and is part of our duty as a community of neurosurgeons to find out the way adapting the system to reduce such cases. Despite massive strain on the healthcare system, neurosurgery department must balance urgent and emergent disease processes, public health concern regarding disease transmission through this community, and the safety of the department staff. And how we do that? Okay, in the way to find the answer, and with this conference proposal, I carried out a review of articles in PubMed until January of this year by using the keywords COVID-19 and neurosurgery. The search yielded an initial set of 1,162 articles, most of them review articles. A few of them are guidelines or recommendations. Additionally, documents published on websites or various international neurosurgical and relevant medical societies were reviewed. As the number of scientific reports increasing daily, it becomes imperative to filter the information, and the aim of this representation is to review the most recent recommendations. For this purpose, I have divided the information in 7 sections. The first one is the organization of infrastructure in case of need, of course. Second one talks about clinic scheduling and the importance of telemedicine. Third one is scheduling neurosurgical cases in non-emergent ones. Fourth section is about emergent neurosurgical cases and hospital staff organization. The 5th point is protection of operating room staff. The 6th point are some surgical considerations. And the last one is about neurosurgical training. Talking about the organization of infrastructure, the goals at this point should be preserve intensive care unit beds, optimizing cost-effective utilization of resources for COVID-19 patients and reduce cross-infection. Remodeling the hospital system by identifying concentration centers for neurosurgical activities is necessary to manage emergent and urgent cases. A clear example in this health system is in Lombardy, Italy. It was rearranged as a spoke and hub system. The total of neurosurgical network was assembled in 4 hub hospitals, 3 for cranial and spine emergencies and 1 for oncological cases. All other neurosurgery departments served as spokes. In this way, hub hospitals were available to attend all neurosurgical emergencies, whereas spoke hospital concentrate on patients with COVID-19. In Uruguay, as the cases were controlled until the last month, neurosurgical departments still open, but we created a separated public hospital to concentrate all patients with COVID-19. What should we do with the outpatient care? The goal is to reduce the patients in hospital in order to ensure patient safety and minimize the exposure of healthcare providers without compromising patients' care. The recommendations are in favor, according to physicians' preference, patient follow-up and appointments should be performed by telemedicine. According to Harvard Medical School experience, more than 80% of outpatient visits have been switched for telemedicine, and also telemedicine is validated by a study from Germany presenting comparable results to bedside examination. There is some condition that requires more exhaustive physical examination as peripheral nerves or spine, but visits should be reserved for selected cases. In addition, patients aged more than 65 years old and such patients with major comorbidities should be encouraged to avoid visiting the outpatient clinic. The work schedule should be organized with a minimal staff as needed, using always appropriate personal protective equipment. That comprehends disposable surgical cap, mask and latex gloves with isolation clothing. And what about the scheduling neurosurgical cases? Our recommendations are in the way of postpone or cancel elective surgeries at the peak of this pandemic in order to preserve supplies. Also, these recommendations are helpful. They do not address how to triage cases that require surgery in a brief period of time. Apart from clear-cut emergent cases, the timing of neurosurgery may be crucial, even in some elective procedures, such as intracranial tumors or cervical myelopathy. Berg and collaborators performed a literature review and consulted with Chinese neurosurgeons who provided first-hand experience and designed a system according to surge level. They proposed schedule neurosurgical cases according to the level of viral disease in the community at real time. It's a sort of volume limiting approach. Using the current surge level is given a color code that correlates with the rising viral transmission and goes from green to black. This approach encourages maximal adaptability in which the supply of hospital capability meets the demand of scheduling need. This figure or this chart represents the volume limiting approach. The search criteria are shown in the left column, the emergent case and the elective in the middle, 2 columns, and the transfer center recommendations is in the right one. Depending on the search level is the percentage of elective surgeries reduction. In the green level, all elective cases proceed as a schedule. In the yellow level, the operating room schedule is capped for 3 weeks to 75% of capacity. That means 25% reduction in elective surgeries. In the red level, there is a 50% of reduction in all elective case scheduling. And finally, in the black level, in which significant governmental resources are needed, all elective surgeries will be cancelled. There are numerous proposals of triaging recommendation, mostly of them based on the urgency criteria. This image or this chart is showing a consensus of the timing of neurosurgical scenarios. It was made by the Delphi study and has the advantage of listing examples of neurosurgical disease and related action. It was designed based on the Delphi method, in which 22 attending neurosurgeons in active practice in the United States were black label surgeries had been occurring a direct result of COVID-19. 14 from the New York and 8 from the Detroit metropolitan areas were interviewed to indicate the appropriate timing of surgery in the most frequently surgical scenarios. Time frames in the first row were divided into 6 years. Emergent is a life or limb risk should be done within 24 hours. The rest of the categories are 48 hours, 1 week, 2 weeks, 4 weeks, and the last one is more than 4 weeks. Consensus was predefined as an agreement among 75% of the experts. A total of 78% reached the predefined consensus after 2 survey rounds. This guide could be useful as a recommendation of surgical timing for a better organization. But at the end, all plans for scheduling of neurosurgical interventions should rely on an expert opinion from a board-certified neurosurgeon based on patient's condition. Don't forget that it's mandatory to shorten the length of hospital stay of these operated patients in order to minimize the risk of exposure. This is also a proposed chart for scheduling form using recommendations announced by the European Association of Neurosurgical Societies and American Association of Neurological Surgeons, between others. In this chart, they divide common neurosurgical scenarios in low, intermediate, and high acuity surgeries. The goal, what happened with emergent neurosurgical cases? The goal at this point is at all levels of outbreak, the emergent neurosurgical cases must be ensured with an uninterrupted inpatient coverage, at the same time minimizing patients and provider viral exposure. In order to optimize resource utilization, Berg and collaborators recommends a paired coverage model of resident physicians and healthcare provider groups. 2 teams that switch coverage on a 3-day cycle and an alternate group that substitute for any team member who shows signs of illness. In this way, if a team becomes positive, the other team will take over and alternate will fill the gap. An important thing is that each team will only rotate at one hospital with no cross-covering accepted. The transition between teams should be virtually, avoiding unnecessary team-to-team contact. Berg and collaborators also propose a checklist to help to organize the surgical staff during the crisis. This is the checklist. It's for time reasons, I'm not going to stop here, but it could be useful too. Okay, what's happening with protection of operating room staff? This is the 5 point, and it's very important. Healthcare personnel, including operating room staff, are at high level risk of exposure to this virus. Up to 29% of confirmed cases were in healthcare staff in the initial cohort reports. Minimal or no symptoms are observed during the incubation period, the first 3 to 6 days in most cases. However, these patients are able to spread the virus. That's why every patient should be considered as positive one until proven otherwise. All patients indicated surgery must be screened for COVID-19 with a SARS, with a PCR or antibody test. Also, measure of body temperature and perform a respiratory symptoms investigation must be made. Some authors also recommend thorax CT scan. Different recommendations are present for COVID negative patients. Some of them suggest that patients at low risk areas who are verified COVID-19 negative can be operated with standard protection equipment, disposable surgical cap, mask, gloves, and isolation clothing. Other authors suggest also medical protective mask and 95 and goggles. For patients who are suspected or confirmed positive for COVID-19, the protective personal equipment must be disposable surgical cap, protective uniform and latex gloves, medical protective mask N95, and full face respiratory protective device or powered air purifying respirator. The route from the ward to the operating room should be clear. The operating room of COVID-19 positive patients should be separate. An operating room of COVID-19 positive patients must be with negative atmospheric pressure setting and with independent access. Because the intubation can generate aerosols, it should be performed via the method with the maximum possibility of first-time success, using, for example, by the laryngoscope. All the operating room staff should be wearing full protection personal equipment and, of course, being previously trained on that. After extubation, it's recommended that a patient wears a surgical mask as soon as possible. And during the pandemic, the staff number in the operating room must be reduced to the minimum. What about surgical consideration? Just a little. Powered instruments as high-speed reels, which are commonly used tools for cranial and spinal procedures, produce blood containing aerosols, and hemoglobin has been identified in the ambient air. And these aerosols could be contagious. Attention should be paid to minimize an aerosol generation in operation. More meticulous irrigation and reduction of drill speed, special cautions should be taken during an anterior skull-based surgery to avoid communication with frontal or ethmoidal cells. The use of monopolar or bipolar creates a gaseous byproduct containing aerosol and should be reduced. Another recommendation is the endonasal transesophageal endoscopic surgical approach should be avoided during this pandemic. Alternative routes to endoscopic surgery should be considered for patients that cannot be postponed, like craniotomy and microscopic endonasal transesophageal surgery. The COVID-19 pandemic has impacted every facet of global population. The entire health system, including neurosurgical practice, have dramatically changed. Medical and surgical residents around the world have been experiencing drastic changes, also in their normal clinic schedules and academic curricula, including reduction in elective operating volume in favor of telemedicine and teleconferencing educational activities. Several reports from universities in the USA emphasize the importance of making changes in the responsibilities and education of neurosurgery residents in order to ensure their safety. And just for ending, I want to encourage all of you residents to be strong, self-disciplined, creative, and resilient. I truly hope that COVID-19 outbreak will soon end. Thank you very much.
Yeah, thank you, Dr. Maria Fernanda. It's also a great talk. Now we had the part with the presentation, part without presentation, so it's really great combined. Yeah, as Dr. Maria Méndez told, like, it seems that you did a great job on all this, because I'm sure it is a great amount of things you have to deal with to create this presentation, and you really touched the important topic for nowadays, for today. And I'm a resident as well, and I think other students and residents who are watching us now, they took something, managed to catch some important points from your talk, and we'll do some conclusions. And I hope we will overcome this problem and we'll come back to the usual life, to the normal life, but with experience we got during this period. Like, it's really important. So thank you for both of you. Like, we have two Marias, we have Make-A-Wish right here now.
Thank you.
So that's it. Okay, so we are grateful to everyone. We are grateful to Dr. Francisco, to our speakers, to Dr. Herrera, to organizers, to Neurosurgical TV for broadcasting this. And we hope to see everyone in our second lecture, which was announced in our social media. So really thank you, everyone, and see you. So, Dr. Francisco, we can finish the live streaming.
Yes.
We are still live?
Yes, we are online.
Okay. So nice. We have our second lecture, and can we join by the same, we will join by the same link, right?
Right.
Okay, and can we start like 10 minutes in advance because the doctor asked us? Okay, so now we are not live. It's really nice to get to know you. Really thank you, Dr. Maria Méndez, for joining us. And I saw you have a really nice dog on your picture. I also like dogs. My family has 4 of them and I grew up with them, so it's really nice. And that's it. So, okay, we will finish for now. I think, Dr. Francisco, how many people watched us? Can you say like now or approximately?
Like 2.
No.
Oh.
15. It's morning in Mexico. This is the
I
pro.
like yeah, but that's good. Actually it is all recorded, so it will be on Facebook, on YouTube, so people can watch it later. So
yes,
it's not a problem. So thank you very much. Thank you to Dr. Herrera one more time. We will say it to him and see you. Bye bye.
Bye bye.
Bye.
See you, Dr. Francisco. So we will join in 10 or 15 minutes before the time when the doctor Hirschkamp from Germany will speak, okay?
Okay.
So see you, bye.
See you, bye.